Shall I start? Welcome, dignitaries. Pallavi ma'am, shall we start?
Yes, ma'am. Please go ahead.
Bhagavad Gita quotes, Nahi jnanena sadrisha pavitramahi vidyate. There is nothing in this world more sacred than the knowledge. Whosoever personally achieves success in this yoga of divine knowledge realizes this truth. Knowledge is the key to open door to wisdom, prosperity, and happiness. Knowledge is power. So Raigad IIP with Maha IIP is taking journal journey activity. We welcome Maha IIP President Dr. Hemant Gangolia and ask for his blessings in 1 minute.
Thank you, madam. Good evening and namaste to all the respected dignitaries, faculty, all the attendees on this Zoom dais, as well as all the attendees on the Maha IIP YouTube channel, and wish each one and all happy Maharashtra Day. Today is our Maharashtra Day, so we like to celebrate our Maharashtra Day. Happy Maharashtra Day to everyone. As well, this reminds of our PG days of reading the journal, and we are very fortunate to have these 3 articles to be read by the speakers, and they giving the gist of knowledge in a span of only 10 minutes. So let us, and this is the first episode which we are having with 3 articles. Hope so it will be a wonderful session, and I'm sure with all the dignitaries it will be a wonderful session. Wish each one and all a happy learning. Thank you, madam.
Thank you. Thank you, sir. And may I request our guide, Dr. Vijay Kamble, sir, Professor MGM Hospital, Kalamboli, to share his thoughts.
Good evening, everybody. Actually, when the process started, 3 of our presenters, we contacted each other and decided these presenters only have selected many articles. Initially, we decided we will take 2 Indian articles and 1 foreign article. But with the liking of my very sincere presenter, we have ultimately decided to present 2 articles which are foreign. They are from New England Journal of Medicine, and 1 article which is Indian article. So my first presenter will be Dr. Rahul Kopikar. So he will be presenting magnesium sulfate nebulization for treatment of PPHN. PPHN, although is a common condition nowadays because of difficult deliveries, so it will give some insights and some discussion with our mentor Dr. Sandeep Kadam will be there. Next topic also is by Dr. Kavish Mehta, sorry. He will be presenting the threshold for hypoglycemia, how much level should be of glucose to treat. So that is also from this article is from NEJM, whereas Rahul Kopikar is from Indian Journal of Pediatrics. And third article will be Dr. Trupti Mahatme. She will be presenting on short course of tuberculosis treatment in non-severe pulmonary TB. So Dr. Sushant Mane, who is a doyen of pediatric TB, today only we have 1 program along with him, so he will be guiding us on this journal journey tour. And we have told that even Chitra Kulkarni madam time limit. So we'll be definitely, we have practice, so we'll stick to the time. And thank you, madam. Thank you, Maha IIP, for giving us the chance. Thank you.
Thank you. Thank you, Kamle sir. Now may I invite guest of honor, Dr. Narendra Naniwadekar sir, to give blessings for today's program. He is our CIIP EB member.
गुड इव्हिनिंग एव्हरीवन आणि सर्वांना महाराष्ट्र दिनाच्या शुभेच्छा. आज आपला महाराष्ट्र दिन आहे आणि या मुहूर्तावरती आपण जर्नल क्लबचं हे आजचा प्रोग्राम करतो आहोत. आणि लास्ट टाइमचाही प्रोग्राम आपण अटेंड केला होता. आत्ताही बघितलं तर सर्व टॉपिक्स जे निवडलेले आहेत हे सर्वच्या सर्व टॉपिक्स हे आपल्या प्रॅक्टिसला बदल घडवू शकतील अशा पद्धतीचे आहेत. तेव्हा नुसतंच आपलं काहीतरी एक आर्टिकल आहे आणि ते वाचलंय असं होणार नाहीये, बिकॉज आपल्याकडे सुद्धा आमच्या कोल्हापूरमध्ये सुद्धा जेव्हा जेव्हा जनरल क्लबचं हे होतं त्यास आम्हाला त्या प्रॅक्टिसमध्ये त्याचा काय फायदा होणार आहे हा विचार करून टॉपिक सिलेक्ट केले जातात. सो ऑल द बेस्ट टू ऑल द 3 पार्टिसिपेंट्स अँड ऑफकोर्स त्यांच्या पाठी एक्सपर्ट्स असणार आहेत त्यांचे एक्सपर्ट कमेंट घेण्यासाठी. सो ब्लेसिंग्स फ्रॉम माय साइड. गो अहेड. थँक्यू.
मॅडम अनम्यूट करा. मॅडम अनम्यूट करा.
I hand over my baton to Maharashtra IAP Core Committee member Dr. Neha Singh.
Before Dr. Neha starts, Madam Chitra Kulkarni, just call Dr. Sushant Mane. He is not there.
He will be joining.
Okay.
He is in emergency, VIP emergency.
Okay.
He will be joining later.
He will join before 9:30, sir.
Thank you, Chitra ma'am. As already Vijay sir has explained, today's journal journey we have with us 3 presenters, Dr. Kavish Mehta, Dr. Rahul Kopikar, and Dr. Tripti Mane, and 2 experts, Dr. Sandeep Kadam and Dr. Sushant Mane with us, who will be guiding us throughout the journal journey. Now I invite our state convener, Dr. Jay Bhandarkar sir, to please introduce our presenters and start the journal journey. Over to you, sir.
थँक्यू नेहा. नमस्कार सगळ्यांना. महाराष्ट्र दिनाच्या शुभेच्छा. आणि महत्वाचं आहे की आज या दिनी म्हणजे आपण परत जातोय आपण आपल्या अकॅडमिक्सकडे. तर जर्नी जनरल हा आपण चालू केला हा गेल्या वर्षी चालू केला डॉक्टर्स डेला. तर आय थिंक हाच म्हणते दुग्ध शर्करा योग आज जुळून आला की संडे आहे आणि वी आर ॲट क्वाईट रिलॅक्स ॲट होम and as well as we are going to enjoy the journey journal. So we are blessed with the very good senior experts. Dr. Sandeep, a near dear friend from Pune. He is a senior concerned neonatologist from KEIM Hospital, Pune. आणि सरांचं मी थँक्यू म्हणतो की त्यांनी जॉईन ॲज इमिजिएट ही रिस्पॉन्डेड की येस आय एम गोइंग टू कम. सो थँक्यू सर. अँड आवर फर्स्ट प्रेझेंटर इज व्हेरी स्मार्ट लुकिंग आवर राहुल कोपीकर doctor from Nashik, and he is MBBS DCS and DNB fellow from and he is working as assistant professor of at Vasantrao Power Medical College, Nashik, and his topic is already declared is nebulized magnesium sulfate for treatment of persistent pulmonary hypertension and newborn, a pilot randomized control trial. So welcome Rahul. And our next presenter is again very young dynamic neonatologist from Nashik only, Dr. Kavish Mehta, and he is MBBS DCH and neonatologist, fellow neonatology IIP, working as the Shishukal Clinic, Safalya and Safalya Hospital, Nashik. And we're going to present this lower versus traditional threshold for neonatal hypoglycemia. Welcome Kavish. And all the best for today's journey journal. We're going to do best for our own fraternity. Thank you. So, and I just just invite Dr. Rahul to start his presentation.
Thank you, sir.
My slides visible?
Yes.
Yes, Rahul.
Yes.
Firstly, I'd like to thank all the seniors, the stalwarts, the experts, and the organizers for this wonderful event that has been organized, and this incredible opportunity for me to present this article to all of you today. My topic is nebulized magnesium sulfate for the treatment of persistent pulmonary hypertension of the newborn, a pilot randomized controlled trial. This article was published in the Indian Journal of Pediatrics in the August 2021 issue. We all know that PPHN is a very common and life-threatening problem in the NICU, with significant mortality and neurodevelopmental impairment. The management of PPHN includes optimization of oxygenation, ventilation, hemodynamics, but there is a significant role for pulmonary vasodilators. Inhaled nitric oxide and sildenafil are the established treatment options, but they are expensive and not always easily available to many NICUs. So why this particular study? So magnesium sulfate is an effective vasodilator that can reduce pulmonary pressures. It is cost effective and easily available. The problem is it is not a selective vasodilator. When we give this drug by IV route, it causes significant systemic hypotension. And the clinical evidence for its use in PPHN is conflicting. So the author's hypothesis is that if we give nebulized magnesium sulfate, this may enhance the effectiveness and minimize the systemic adverse effects compared to IV route. The Cochrane review about the use of magnesium sulfate in PPHN says that there is not enough evidence to recommend this drug routinely for PPHN treatment, and they recommend further randomized controlled trials. So this study is an example of such a trial that has been conducted. So what is the research question of this particular study? The research question is, what is the effectiveness and safety of nebulized magnesium sulfate compared to intravenous magnesium sulfate in treating ventilated term newborns with PPHN in the NICU? And the hypothesis is that nebulized magnesium sulfate is more effective and safer compared to IV magnesium sulfate in this population. This is a double-blinded, randomized, parallel, two-arm proof of concept clinical trial and was conducted in a level 3 NICU in a tertiary care center in Egypt. The study duration was almost 3 years, and the study population was ventilated term newborns with a birth weight between 2.5 and 4 kg, with a postnatal age between 6 and 72 hours of life, with echo-confirmed PPHN. The interventions were given to 2 groups. So the neonates were divided into a nebulized magnesium sulfate group and an IV magnesium sulfate group. The NebMag group received nebulized MagSulf and IV placebo, and the IV Mag group received IV MagSulf and nebulized placebo. So both groups received IV and nebulization, one group with nebulized and one group with IV. The masking was triple, that is, participants, care providers, and outcome assessors, all 3 were masked. And the randomization was done using computer-generated numbers, which were sealed in sequentially numbered opaque envelopes, so a standard method of randomization. The inclusion criteria we've already discussed, but the exclusion criteria was very selective. Those who could not obtain consent were obviously excluded. Neonates of mothers who had received MagSulf before labor were excluded. Any newborn with congenital heart disease or any major congenital anomaly was excluded. Any neonate with prior CPR was excluded. Any newborn who had mean arterial blood pressure less than 35 millimeters of mercury, that means with hypotension, was not taken in the study. And prior administration of any other pulmonary vasodilator was also excluded. So that means nobody in this trial received any other pulmonary vasodilator like sildenafil. So what were the outcome measures? The main primary outcome was a change in the oxygenation index at baseline at 2 hours, 6 hours, 12 hours, and 24 hours following drug administration. The secondary outcomes were 3. One is a change in the mean arterial blood pressure at the same timelines that were described earlier. And second one was a change in the serum magnesium level. And third is changes in the vasoactive inotropic score, again at the same timelines. So what is oxygenation index? This is mean airway pressure into FiO2 divided by PaO2. This is a measure of the degree of hypoxemic respiratory failure. And in this study, we are using this as a response to measure the response to treatment after drug administration. Vasoactive inotropic score is a composite score that has been created to bring the dose of different inotropes to the same level. So for example, the average dose of dopamine is 10 microgram per kg per minute, and the average dose of adrenaline would be 0.1 microgram per kg per minute. So to bring adrenaline to the same level as dopamine, they have multiplied it by 100. And similar multiplication factors have been given for different inotropes. It's just a composite measure of inotrope requirement. The results of the study, 219 newborns were screened with PPHN, that is. From them, only 81 were deemed eligible for the study. From these 81 newborns, 37 of them had some exclusion criteria, so they were excluded. 16 of them did not give consent, so they were out. And that we were left with 28 newborns that were successfully randomized into the 2 groups, the NebMag group and the IV Mag group, 14 in each group, and all 14 did receive the intervention and completed the study and were analyzed. I'll describe the results in 3 main graphs. This is the first and most important diagram. This is the change in the oxygenation index, the primary outcome. On the x-axis, we have the study timeline from the time of drug administration and followed up at 2 hours, 6 hours, 12 hours, and 24 hours. And on the y-axis, we have the oxygenation index. We can see 2 lines here. The dotted line represents the IV magnesium sulfate group, and the dark continuous line represents the nebulized magnesium sulfate group. Clear from this diagram is that in both groups, there is a fall in the oxygenation index after the drug is administered. That means when you give Maxel, definitely oxygenation index improves, whether you give IV or nebulization. But when you proceed with the study, over a period of time, the difference becomes more. And at 24 hours following drug administration, the nebulized magnesium sulfate group has a significantly lower oxygenation index compared to the IV nebulization group. So proving that it is probably more effective than IV magnesium sulfate in treatment of PPHN. This is the second graph. In this second diagram, you can see the changes in the mean arterial blood pressure in the same two groups. Here it is very clear that the dotted line, which is the IV magnesium sulfate group, has overall a lower mean arterial blood pressure compared to nebulized magnesium sulfate. That means more hypotension occurs when you give Magsulf by the IV route than by the nebulization group. And this is the third figure. This is the changes in the vasoactive inotrope score, the inotrope requirements. Again, here we can see that the inotrope requirement for the IV group, the dotted line, is much higher than the nebulized magnesium sulfate groups, much lesser inotrope requirement when you give Magsulf by nebulization group. The last two diagrams prove that the nebulized magnesium sulfate is basically safer, fewer adverse effects like hypotension compared to the IV group. So the conclusions of the study are the nebulized magnesium sulfate may be an effective and safe therapeutic modality for neonates with severe PPHN on mechanical ventilation, but obviously we need larger studies to confirm this information. What are the strengths of this study? This is the first clinical trial that is trying to investigate the effectiveness of nebulized magnesium sulfate. There are some trials with the IV Magsulf before, but with nebulized magnesium sulfate, this is probably one of the first. Very specific inclusion and exclusion criteria is there. So there's no ambiguity about the selection of study subjects. Of course, you can look at this as a strength also and a limitation also. Because it is such a narrow group, you may not be able to extrapolate these findings to all newborns with PPHN, for example. But this is a pilot study. It lays down a very good framework to design future multicentric trials. The outcome measures here can be used as a basis to design sample size for larger studies. Limitations of the study are many. Most importantly, a small sample size and a very limited study time frame. They've only studied up to 24 hours. One important thing was that the details of who administered the intervention, who recorded the outcome has not been very clearly mentioned. So that is one limitation in the study. And most importantly, from a practical standpoint, very important outcomes that we want, like length of NICU stay, survival rate, a long-term neurodevelopmental outcome, this has not really been assessed in this trial. So you can't, on the basis of this trial, blindly recommend the use of nebulized magnesium sulfate. What are the implications for practice and for future research? As we discussed already, a very well-designed trial, which is trying to incorporate a known drug for an off-label indication, but within the framework of a controlled trial. The most interesting part for me was that the description of the NICU where this study was conducted is very similar to the NICUs most of us work in. Even small private sector NICUs that we have ventilators, have infusion pumps, we have trained nurses, but very often we don't have inhaled nitric oxide, HFOV, and ECMO. And so this description matches most of the NICUs that we work in, and it provides hope for a cost-effective solution by an innovative route for newborns with such conditions in NICUs. Thank you.
Rahul, good evening.
Good evening, sir.
At the outset, I would like to thank all the office bearers and the seniors for giving us this opportunity for this evening to discuss two relevant journal articles. When you look at this article, if you critically appraise, you have rightly said the strengths and the weaknesses. Do you find that the primary outcome was a robust outcome that we would use in our day-to-day clinical practice?
I think from what I understand, it was used mainly because they wanted to check this as a proof of concept trial. So probably to judge the drug, it makes sense. But clinically for us, there are many other outcomes. How long the baby was on a ventilator, how quickly they could extubate, mortality, these things, I guess.
So I think for you and me, when you look at PPHN, the first most important outcome is survival.
Yes.
And I think that survival as a primary outcome would have been more relevant, or a neurological outcome at 18 months, rather than looking at an oxygenation index, which is a very pseudo relevant indicator, number one. Number two, when you look at the intervention, they looked at IV magnesium sulfate versus nebulized magnesium sulfate. But if you look at the title of the article, it is nebulized magnesium sulfate for PPHN. So the clarity of intervention is not coming out from the title of the study. Number three, if you look at the composition of magnesium sulfate in nebulized solution, they have used distilled water as a diluent, and I'm not sure whether distilled water is a good diluent. And in fact, as a matter of fact, it is contraindicated for nebulization in children and infants. So one would use normal saline and not distilled water. Number four, what they have looked at so many blood gases at 2, 6, 12, 24 hours to calculate the oxygenation index, which makes it more impractical. So probably their aim was something different, and they have ended up publishing the trial in the journal, which probably is good in terms of academic research, but not for clinicians and clinical research. In today's time and era, one would probably have better pulmonary vasodilators like milrinone and sildenafil. So role of magnesium sulfate, which is a very general non-specific vasodilator, would probably go down in the hierarchy to one would probably not consider magnesium sulfate because we have got good ventilation. Because if you look at management of PPHN, it is holistic management. When you look at recruitment of alveolar, ventilation of the lungs at FRC, good supportive care, you increasing the mean arterial blood pressure, and then considering use of pulmonary vasodilators like sildenafil or milrinone, depending on the cause. So herein, probably this intervention, whether it has got validity for use in our own context, is what we need to answer. And I'm sure with so many good strategies in day-to-day practice, one would probably refrain or go away from using magnesium sulfate in today's time and era. Yes, probably there may be a role in resistant cases where there is no response to the standard line of management and nitric oxide is not available. One could probably try a rescue magnesium sulfate. And herein, probably what they have shown is that nebulized magnesium sulfate is better than intravenous magnesium sulfate. I think that is what is coming out of this article, but I'm not sure whether it has relevance for use in day-to-day practice from tomorrow morning.
Yes.
I mean, these were my critical inputs. I'm happy to have some questions if there are any in the chat box.
Sir,
May I ask
we
one
don't
question,
have
sir?
that much time.
Okay, no problem.
We should go to second article.
Yeah, Dr. Kavish, please.
And very nice presentation, Rahul. Very happy to see you.
Is it visible, ma'am?
Yes, sir.
Yes, Kavish. Yeah.
Thank you, all of you. And thank you, Maha IP and IIP Raigad for starting this journal club, which has led us to read many new things and come up with some good article. My article for today comes from the New England Journal of Medicine. It says that the hypothesis is lower versus traditional treatment threshold for neonatal hypoglycemia. This study is a part of a group called as hypo-exit group. Hypo-exit group is a hypoglycemia with extensive treatment or extensive monitoring or intensive treatment study group. The current knowledge about this is current threshold to treat the high-risk babies with asymptomatic hypoglycemia is less than 45 milligram per DL. And treatment options which we usually have in our NICUs are enteral feed, tube feeds, and IV glucose. So babies with neonatal hypoglycemia are at increased risk for delayed motor and cognitive development that may manifest later in life. And infants who have experienced seizures secondary to metabolic derangement, example hypoglycemia, carry 10 to 50% risk of subsequent neurodevelopmental abnormality. So till date, we have only have related to this topic, we have observational studies. There are very less or maybe no randomized control study related to this topic. So basically, why this study? So currently there are no consensus on the threshold glucose concentration at which the treatment of asymptomatic neonatal hypoglycemia should be initiated. And this study aims at observing lower versus the traditional treatment threshold of neonatal hypoglycemia in near term, more than 35 weeks baby, SGA, LGA, and IDM babies. This group of neonates almost have a high incidence of almost 50% of cases of neonatal hypoglycemia. And what are the implications on the cognitive and motor development by observing them at 18 months of age with a Bailey scale of infant and toddler development, third edition and Dutch version of it. With a goal of preventing brain injury, usually will lead to overpricks and overtreatment. This study gives an input in this issue also. Implications on mother and baby's hospital stay is also included in this study. So basically, this is a multi-center randomized non-inferiority trial. There are almost 17 hospitals which were involved, and it took a period of around 4 years to complete this study. For division purpose, for randomization was done in group A and group B. Group A was a lower threshold group, and the treatment was started if at all the sugar went below 36 milligram per DL. And in group B, that is a traditional threshold group, treatment started when the sugars were less than 47 milligram per DL. Randomization was done, and the sugars were checked between 3 and 24 hours after birth. So inclusion criteria I discussed in the earlier slide. In exclusion, the exclusion was quite strict. Babies who had severe asphyxia post-birth, those who required supports of vital function, those who received IV glucose before the trial, and those babies who had suspected syndrome, severe congenital malformation, IEM baby who had IEM and hyperinsulinemia, and babies whose first glucose was more than equal to 47 or less than equal to 35 milligram per DL, and those babies who didn't have informed consent were excluded. So total of 5,948 babies were included in the study. Then considering the exclusion criteria, only 689 babies were left, which were then randomized to two subgroups as discussed earlier. Was group A was 348 babies and group B had 341 babies, out of which in group A 287 babies came for the follow-up at 18 months, and 295 of 341 babies followed up at 18 months in group B. So the interventions used in this trial were that if at all the glucose concentration falls below the threshold, then the intervention was to increase the carbohydrate intake by 1 mg per kg per minute and check the glucose level after 1 hour. The treatment interventions were supplemental oral feeds, tube feeds, and IV glucose. So over here, the intention to treat analysis was made. That means that all the patients included in the statistical analysis are analyzed regardless of what the treatment they receive. So this is a little bit busy slide. Like primary outcome in this, I would minimize to one line, that is Bailey's 3 NL scores at 18 months of age were similar in both the groups, like in the lower threshold group and the traditional threshold group. So there is a graph also to tell forest chart. So in this forest chart, the mean absolute difference between the newborns assigned to the lower threshold group and those assigned to the traditional threshold group with respect to the cognitive scores and the motor scores on the Bailey's scale is depicted over here. So as we can see, the normal Bailey score is from 40 to 160, and the mean comes to around 100 with a standard deviation of plus minus 15. So in this chart, they have study, they have considered the half of the standard deviation, that is minus 7.5, as a inferior limit. So as we can see in both the charts, the mean has not, it is towards the lower threshold, is directly seen as a non-inferior to the traditional threshold. And in the secondary outcomes, there is a glucose measurement and treatment required were less in group A. Number needed to treat was 7 for IV glucose administration and was 12 for tube feeding babies, and it was 5 for supplemental oral feeding. None of the infants had any clinical signs and symptoms of hypoglycemia, and duration of the hospital stay for babies and mother are same in both the groups. Serious side effects were seen in 2 babies in group A, but in that also one baby had some respiratory issue in the post neonatal period, and the other baby was had some issue had seizures while he was undergoing MRI, but at that time he was normoglycemic. So they both are not very significant to be considered in this study. Talking about the limitations of the study, 16% had lost follow-up, and the babies who are less than 2 kg, less than 35 weeks, and after 48 hours of life, and the sick babies are not included in it. And some important facets of cognitive and the social functioning, such as the executive functioning, the language comprehension, speech, and more complex visual motor integration, which develop after 18 months of age, are not assessed in this study. So follow-up trial is required, and relevance to Indian babies is also questionable because it is a Dutch version of this study. What this study adds in our day-to-day practice is allowing a glucose concentration of 36 milligram per DL or higher in first 48 hours of life after birth. It is we can accept it and associate it, the association with the developmental outcome that were similar or non-inferior to those observed in the traditional treatment group. And the number of pricks required in the low threshold group is less comparatively. So with this, I end my
Yeah, Kavish, very nicely compiled study. This was one of the biggest RCTs in the field of hypoglycemia. And at the end of it, I think we are still more confused at a higher level than what we were confused before reading the study. If you critically appraise, do you think we need to change the practice of following 47 versus 36 after reading this article? What is your view on this?
Sir, I feel at least less than 47 means more than 36. Definitely, we need not prick much. We can come down on the even the hospital stay, even separation from mother. Usually, what happens in our setup is like we separate the baby and keep the baby in the NICU. At least we should not get panic, and we can observe after 1 hour and again see the levels.
So mind well, I think what was our inclusion criteria? These were asymptomatic babies.
More than 35-week baby, more than 2 kg,
Yeah.
Small for gestation age and large for gestation age, and infant of diabetic mothers.
Correct. So if you look at this group of bunch of babies, we are talking of blood sugar on day 1 and day 2, that is less than 48 hours. And the babies were more than 35 weeks. The babies were more than 2 kilos. They were either large babies or they were infants of diabetic mothers. I think what probably we understand is that it is not just one blood glucose which is going to correlate with the cognitive or psychomotor outcome at 18 months. There are lot many things which are happening in these babies. Now, for instance, if you take 100 postnatal ward babies, well babies with a mother, and if I do a blood sugar assessment, I'm sure we would find at least 10 to 15% of these babies would have a blood glucose less than 40. So there is a questionable definition or ambiguity about definition of various thresholds. Various bodies, various experts have labeled hypoglycemia in the first 24 to 48 hours as cutoffs less than 47, less than 40, less than 36. Some people to the extent that it may be less than 25. So nobody knows the real truth. And we probably are harboring around some numbers. And that's why this study came into existence of low versus traditional threshold. Number two, in the first 24 to 48 hours, when the baby is on mother's milk, there are a lot of things which happen. There may be gluconeogenesis, there may be glycogenolysis, and most important, ketone bodies are being generated. And if you have ketones, then your brain can use ketone bodies in absence of sugar. So even if the blood glucose is less, then probably ketone bodies are used by the brain, so the neurological handicap is probably less severe or not as much as we would think. That is the basics of this study, which is showing the results that it is non-inferior. So probably it is more or less equal. So that brings us to the next issue. If we have to do a blood glucose, why would one do a blood glucose levels in asymptomatic babies, in a baby who is say more than 35 weeks, who is otherwise fine? So we would probably do it in infants of diabetic mother, we would do it in large babies, we would do it in a small for gestational age baby, less than the 10th centile, and screen for hypoglycemia. But probably our interventions probably would not be as aggressive as one would manage in a traditional hypoglycemia. And as rightly said, in infants of diabetic mother, once there is hyperinsulinemia, it is a hypoketotic hypoglycemia. So ketone bodies may not be available in infants of diabetic mother. That makes them more vulnerable for brain damage in the presence of hypoglycemia versus a normal baby with ketones, because ketones can be used by the brain. So if I see a baby who is infant of a diabetic mother and I see a large baby, both having same weight, and if the sugar is low in an infant of a diabetic mother, that baby is more vulnerable for neurological sequelae as compared to the other baby. So I think that's where we are. What do you think is the generalizability of this study in our day-to-day context?
So I feel that we can avoid NICU admissions for just one sugar which is low, and
Correct.
second.
So probably if the sugar is low, one would probably advise feeding and
feed
and repeat a sugar after 1 hour. Yeah, that's right. Okay.
And
anything else?
Other is yeah, that's it, sir. This is the main, I think.
So we are talking of a very niche or select group of babies in the first 48 hours. Please mind well that this cutoff should not be extrapolated beyond 48 hours of life. Number one, this cutoff should not be extrapolated to any baby who is symptomatic. Because if you have a baby who is symptomatic and hypoglycemic, one needs to be aggressive to manage hypoglycemia. Here we are talking of asymptomatic hypoglycemia, where there is two cutoffs of 47 versus 36. One could probably be a little bit more conservative in terms of managing that 36, but please repeat a blood sugar after 1 hour, though the neurological outcomes were not as bad as it has been shown in this randomized control trial. Yeah, I think this is what my it is not necessary to do ketone bodies in all babies with hypoglycemia. One would do ketone bodies only with refractory hypoglycemia, where your glucose infusion rates goes up more than 12 milligram per kilo per minute, or if there is persistent hypoglycemia. Low ketones with hypoglycemia, you are on fatty acid oxidation defect or hyperinsulinemia, and ketones with hypoglycemia, we are on other metabolic disorders like glycogenolysis or neoglucogenetic disorders.
Thank you. Thank you, sir.
Thank you, madam.
Thank you. Very nice and crisp presentation as well as good discussion. So moving ahead with the third topic today, I think our expert, Dr. Sushant Mane, is very busy in his some emergencies, but I think we should.
I have joined, but I try to, be there.
Okay.
Yeah.
Thank you, Sushant. So who are the expert, Dr. Sushant, and I will give a brief introduction of him. Are you sharing his CV slide, madam? Dr. Sushant Mane is associate professor in pediatrics, Government Medical College and JJ Hospital, Mumbai, and is a nodal officer, State Pediatric Center of Excellence for TB, expert in National Technical Expert Group, that's NTP India, and a member of WHO Working Group on Child and Adolescent TB. He was busy all over day, still in emergency joint. Thank you, Sushant, for blessing this our journal of MyIP with Raigad IP. And our
thank you, sir.
welcome. And our presenter is Dr. Tripti Mahatme, and she is from Vasantrao Pawar Medical College, Angaur near Nasik, I know. And can you share a CV here on the slide, please? And thank you for blessing our this journey journal and agreed to present this topic, very important topic. And she's a consultant pediatrician and a lactation consultant and associate professor. Hello, slide kidhar gaya fir se? At Vasantrao Pawar Medical College, Nashik, and she's MBBS, DCS, DNB. I believe this is an EQ trainer. She's special trainer interest in lactation and emotional intelligence in children. And she's going to present this topic on tuberculosis. Welcome, Dr. Tripti, and all the best for today's talk. Thank you.
Are my slides visible?
Yeah.
Yeah. So before I begin, I would like to express my gratitude towards Maha-IIP, IIP Raigad, and all the seniors who had given me opportunity to be here on this platform. My topic of presentation is shorter treatment for non-severe tuberculosis in African and Indian children, known as SHINE trial. This has been published in March 2022 issue of New England Journal of Medicine. I have chosen this topic because I find the content of this study are relevant in our clinical practice, considering magnitude and nature of childhood tuberculosis in our country. Not moving ahead. Yeah. So this is the burden of tuberculosis. Globally, more than 1 million children become ill with tuberculosis. What is more worrisome for us, this global burden is contributed by 31% of Indian children. So why this study was undertaken? We know most children, around 2/3, have non-severe smear-negative tuberculosis. There are few challenges in children like low rates of bacteriologic confirmation, high rates of paucibacillary disease, and difficult collection of respiratory specimens. Due to these difficulties, the clinical efficacy trials in children are lacking. Whatever treatment regimens we implement in children have been extrapolated from adult studies, but in adults, the entry criteria is sputum positivity. In contrast, majority children are smear negative. So as there is limited data regarding the shortening of treatment of drug susceptible tuberculosis in children, the SHINE trial was undertaken to investigate whether 4 months of anti-TB treatment would be as good as 6 months of treatment in children with non-severe smear-negative tuberculosis using new WHO-approved FDC formulations. The trial also evaluated the cost-effectiveness of 4-month treatment approach. Coming to methodology, this is phase 3 clinical endpoint non-inferiority trial. Children less than 16 years of age, more than 3 kg of weight, having non-severe, symptomatic, presumably drug-susceptible, smear-negative tuberculosis from sub-Saharan Africa and India were included in this study. Non-severe tuberculosis comprises of respiratory tuberculosis confined to one lobe with no cavities, no signs of miliary tuberculosis, no complex pleural effusion, and no clinically significant airway obstruction. The study also included paucibacillary disease and peripheral lymph node tuberculosis. The main exclusion criteria were confirmed drug resistance or exposure to an adult with any drug-resistant tuberculosis, smear positivity, and presence of severe tuberculosis on chest X-ray. All the necessary ethical committee approval and consent from caregivers were taken. The study was carried out over 2 years from July 2016 through July 2018. Total number of children who underwent randomization was 1,204. Let us see how the trial was conducted. All the children were screened at enrollment, during randomization, and after starting treatment at defined period of time. The end point of trial was 72 weeks after starting the treatment. The screening procedures included history taking, evaluation of symptoms, and laboratory tests. Tests which were carried out included Mantoux test or interferon gamma release assay depending on the availability, chest X-ray, collection of at least 2 respiratory samples, drug susceptibility testing. Respiratory samples were subjected for smear microscopy, molecular diagnostic tests, and mycobacterial cultures. 5 needle aspirate samples were taken from children with peripheral lymph node tuberculosis. Blood samples were subjected for biochemical and hematological testing, and in children with HIV positivity for HIV type 1 viral load and CD4 counts. Children were followed up at defined intervals with the use of symptom checklist, clinical examination. Repeat respiratory samples were taken if the previous samples were positive. They were reviewed with chest X-ray. Any clinical events suggestive of treatment failure, tuberculosis recurrence, and all the deaths were also reviewed. Adherence of patients was assessed by means of pill counts and administration of adherence questionnaires. Randomization was done by minimization to achieve balance in both the groups over the predictive factors. So this flowchart shows how the randomization was done. Total number of children initially was 1,204, 602 children in each intervention and control group. Out of these, few children were excluded due to various reasons as shown in the slide, and the final per protocol population included 563 and 558 patients respectively in intervention and control group. This table shows demographic and clinical characteristics of the participants. I will highlight only few. The median age of presentation was 3.5 years. The percentage of Indian children in study was 12%. The two centers from where these children were recruited are Indian Research Institute of Tuberculosis, Chennai, and BJ Medical College, Pune. HIV positive status was almost similar in both the groups, 11%. The mycobacterial positivity was seen in 14% of total population. So after randomization, drug regimen was started, initially with intensive phase of 8 weeks in both the groups with 3 to 4 drugs. The ethambutol use was as per the local guidelines. After that, continuation phase was given with 2 drugs, isoniazid and rifampicin, for 8 weeks in intervention group and for 16 weeks in control group. After the end of trial, all the data was statistically analyzed for primary efficacy outcome, primary safety outcome, and secondary efficacy outcome. The calculated power of the study was 90%. So this table shows primary and key secondary outcome. So let us understand primary efficacy outcome means unfavorable status by 72 weeks, which is defined as composite of treatment failure, that is treatment change, extension or restart, or tuberculosis recurrence, death from any cause, loss to follow-up during treatment. So this table shows that the unfavorable status was comparable, that is 3% in both the groups. Let us come to primary safety outcome, which is defined as adverse event of grade 3 or higher during treatment and up to 30 days after treatment. So if we compare the circle numbers, it is seen that numbers in 4-month treatment are less, which shows better safety profile or at least comparable safety profile in both the groups, that is shorter and standard regimen groups. This slide shows the key secondary efficacy outcome, which was again comparable in intervention and control group. The cost-effective analysis showed lower healthcare cost in intervention group, that is with shorter treatment regimen. So to summarize SHINE trial, it evaluated the duration of anti-tuberculosis treatment in children with non-severe, drug-susceptible and smear-negative tuberculosis who were living in countries with high burden of the disease. The trial showed the non-inferiority of 4 months as compared with the standard 6 months of treatment. There was consistency of result across all the analyses. There was good response to treatment with few adverse drug reactions occurred before 4 months. These are the strength of the study. It was well powered. The calculated power was 90%. There was good retention of patients, that is 95% in both the groups. Adherence of patients was 94% in both the groups. Of course, there are certain limitations of the trial. First, this is open label, that is both the researcher and the patient knows about the treatment regimen. So there is potential to result in more frequent treatment extensions, contributing to more unfavorable outcomes in this. Second limitation relates to generalizability of the result to the settings where X-rays are not available, because we can't differentiate between severe or non-severe tuberculosis. So finally, what this study adds to our current knowledge, a positive result from this trial could simplify and shorten the treatment, improve adherence, can be cost saving for many children with tuberculosis and also for healthcare system. It is potentially less toxic, and there is lower risk of drug-drug interaction in children living with HIV. Just an update regarding this study. The WHO Consolidated Guidelines on Tuberculosis, which has been published in March 2022, has recommended 4-month treatment regimen with 3 to 4 drugs, 2-HRZE and 2-HR in children and adolescents between 3 months and 16 years of age with non-severe tuberculosis, of course, without suspicion and evidence of resistant tuberculosis. These recommendations are based on SHINE trial, considering it as the first and only large phase 3 trial to evaluate the duration of TB treatment in children with minimal tuberculosis. With this, I end my presentation. Thank you so much.
Thank you, Dr. Trupti, for crisp presentation. Thank you. Expert comment, please. Dr. Sushant, are we there?
Yeah, I'm there. Am I audible?
Yeah.
So if we look at the SHINE trial, no doubt it is a very wonderfully conducted trial. The sample size is also good. Now, if we look at the trial overall, the whole basis of the trial is they have enrolled all patients with, we can say, minimal tuberculosis or non-severe TB. That is one thing. And as we have seen in the presentation which Madam did, non-severe TB is categorized as only one lobe or maybe a node with not compression. So the whole basis of this trial is on chest X-ray. So the main thing is we have to have a good knowledge of having a chest X-ray. And that is where I think it is a big limitation as far as country like India is concerned, where in most of the peripheral parts at the, even at the district level or sometimes at the sub-central level, a good quality X-ray is not available. That is one thing. And even if it is available, who reads the X-ray? So suppose if any healthcare worker like a pediatrician or a general medicine person is reading the X-ray, is he competent enough to pick up changes in the X-ray chest? It may happen that, there are findings which are missed on the X-ray, or the X-ray is overdiagnosed or underdiagnosed. So, as far as India is concerned, I'm just trying to point out what are the limitations that we may face in incorporating these guidelines immediately. So first is the availability and the reading of X-ray chest at the clinician level. The second thing is, if you see the inclusion criteria, they have taken all smear negative patients and CBNAT with a low level of MTB detection in CBNAT. Again, if you compare it with the status here, as far as India is concerned, we have almost a very high incidence in the country of drug-resistant tuberculosis. As far as the world is concerned, India is, as we know, India is reporting the highest number of TB cases in the whole world, 28% of cases. And out of that, the number of DRTB cases reported in the world is also more as far as India is concerned. And therefore, incorporating such a regimen where we do not have a confirmed microbiological diagnosis, and that too giving it for a reduced number of days, that is from 6 months to 4 months, again, it is a bit risky. The third thing is, at the end of the 4 months, the evaluation was done on clinical grounds. A repeat X-ray test is not being done. We don't know how much resolution of the clinical condition is occurred on the X-ray, and they have not taken the microbiological diagnosis. So we have no means to confirm that the patient has turned microbiologically negative. That is the third thing. And therefore, on follow-up, if even the disease has remained dormant, I mean, if it is incompletely treated, it may stay in the body, and few years later, it may again recur, which is what we call as a reactivation TB, which occurs in the adolescent age group. Now, 72 weeks follow-up, they have said yes, because most of the recurrence, if it has to occur in tuberculosis, occurs in the first 12 to 15 months. Therefore, they have taken 18 months as a cutoff for this, follow-up of these children. But then in our country, we see so many people which come with a reinfection or a recurrence anywhere, beyond 18 months, at 2 years, 5 years, something like that. So what we would be in, and another last point is the number of deaths. There are 31 deaths in the trial, out of which 14 are there in the trial group and 12 are there in the trial group and 19 are there in the 6 months group. They have not quantified deaths. Okay, we need to have an in-depth analysis of each and every death, why these deaths occur, not only in the 4-month group, but also in the 6-month group. Because having deaths in any trial means whether the deaths were due to, it could be a possibility that the disease was not a non-severe disease. It could have been a hidden severe disease or a hidden drug-resistant disease which was not picked up. And because it is a clinical enrollment on X-ray chest, we have wrongly treated the child, something like that. Or whether the deaths were due to severe ADR. So in-depth analysis of the deaths which is there, that is 30 deaths is a huge number for a clinical trial. So that again is lacking in this study. So as far as India is concerned, though WHO has recommended this, now when these guidelines were formed, I was in the expert group with the WHO with 16 member nations of the world. When we were, discussing these guidelines, when this particular guideline was framed, we can reduce the duration of therapy from 6 months to 4 months. So if we read the entire updated module which is come up by WHO, they clearly mention that we have to consider the local prevalence of the disease, the local incidence of the disease, not only disease, but also the incidence of drug resistance, the training of the healthcare staff in reading the X-rays, and quality of and availability of good quality X-rays. If all these things are in place and very well done, then and there only WHO gives a strong recommendation that you can decrease the duration of drug sensitive treatment from 6 months to 4 months. Without this, it is going to be very difficult. And these are the 5 points where our country is lacking. So at present, if we see immediately incorporating these guidelines, that is from reducing to 6 months to 4 months, is not feasible as far as India is concerned. Yes, we might take it again on a research level, because if you see the SHINE trial, only 12% cases were contributed by India. So it is a very low number. Maybe we can use the protocol of the SHINE trial and do a multicentric trial here in India, where we can enroll more number of patients in the same age group and then see how our data fares up. So I think that those are my comments on this. Thank you.
Thank you, Dr. Sushant. So nicely, I think expert का opinion जैसे हो गया. So thank you for that. And there is a question in the chat box.
Yes.
Where TB is mostly possible. So can we truly label it as a non-severe?
Exactly. That is what I discussed. We cannot label that it is a non-severe, because even if it is possibacillary, it could be a possibility that we are dealing with a DRTB. We don't know that. And
Right.
just by diagnosing on X-ray and starting a 4-month therapy becomes very risky in a setting which has a very high incidence of TB.
Yeah. So thank you, Dr. Tripti and Dr. Sushant sir, for taking this article to very high level. I personally apologize. We started last year on Doctor's Day and I was the first presenter. We don't know how to present the article and narrow it, right? Compile it properly, present it, what is the current letter. So I think with every Journey Journal episode, we are blessed with a beautiful presenter and beautiful experts who are guiding us to present better and better way to the journal journey. So thank you, all of you, Dr. Kavish, Dr. Rahul, Sandeep sir, and Tripti again and again, this Sushant sir, for blessing this on Maharashtra Day. So from my IP, I thank you very much. And I again go back to Dr. Neha. She is angry looking at me. आप क्यों thank कर रहे sir? There is this job is assigned to someone else. पण महाआयपी से करणं मला नक्कीच तुम्हाला धन्यवाद म्हणावंच लागेल. कारण एवढ्या क्रिस्प टायमिंग मध्ये परफेक्टली 9 वाजता चालू करून आपण परफेक्टली 10 वाजता थांबलेलो पण आहेत. मला वाटतं हे सगळं त्याचं श्रेय म्हणायला गेला तर प्रेझेंटरला जातं की त्यांनी परफेक्टली मॅडमने अगदी सांगितलं की 8 मिनिटातच करायचं, 10 मिनिटातच करायचं. तर त्यांनी तुम्ही तसंच केलंय. पण ठीक आहे, दिस इज ओके. And thank you, this Kamlesh sir also, for blessing this today's Journey Journal session. So over to Neha for further proceedings.
So Jay, with this crisp timing, also the first episode when I was a second presenter that time, and we struggled, but now if Madam Kulkarni permits, we will continue with these 3 articles. It will be, I think so it will be better to have the glimpse of 3 articles. And if we go this way, it's better to have 3 articles.
Okay. I think questions काही घ्यायचे आहेत.
And Dr. Thank you, Dr. Sandeep, for your valuable presence, as well as Dr. Sushant, Dr. Vijay Kamlesh sir, and all the 3 speakers. I feel I met Kavish when I was at Nashik, when I came to Safalya Hospital. I don't know. With
Yes, sir. Yes, sir.
Yes. Thank you.
Thank you, sir. Now I think so. We already the questions in the chat box have been solved by Dr. Sandeep sir, and now we can proceed with the Thanksgiving.
Before that, Neha, Dr. Narendra is there. Dr. Kedar is there.
Yes.
We can invite them for their comments for 1 or 2 minutes, and then we will just wind up.
Yes, sir. Narendra sir, kindly unmute.
I feel he's
Dr. Kedar sir.
Dr. Kedar. Yes, sir.
Is the past IIP president as well as VP, and at present Nashik IIP president.
Yes, Dr. Narendra sir.
Yeah, I am there. Very good articles. I mean, they have provoked a thought process, and both the experts have given their comments saying that whatever the deficits of the studies as well as the EA. So I think overall a very good discussion. And what I feel is that the way in which these articles are picked up, of course, the deficits or whatever shortcomings were there were pointed out by the experts. But I think this is the way a journal club should go, where the reason for choosing an article, how it will make a difference in our practice is well discussed. And once that is done, the experts have also thrown a light on what are the shortcomings, because an expert only can look at the article with a critical eye.
Right.
So that whatever is seen first need not be the truth. We have to look at the other angles also. Excellent discussion. Thank you.
Yes, Narendra sir, beautifully picked up by the experts. Distilled water I liked.
नरेंद्र सर आता बॅटर तुमच्याकडे आहे पुढचा म्हणून तुम्हाला आम्ही आज बोलवलं.
Yes. We will take good. Yeah, definitely.
Dr. Kedar.
Kedar sir.
Hello.
Video on
Good evening, everyone.
Good
evening, everyone. Yeah. Excellent idea to start this journal club. आणि पहिला एपिसोड होता, बहुतेक मी आज पहिल्यांदाच जॉईन झालो आणि खूप चांगलं वाटलं. 10 मिनिटात परफेक्ट केसेस प्रेझेंटेशन झाल्या. तिन्ही केसेस खूप छान झाल्या. राहुलला मी पहिल्यांदाच ऐकलं. राहुल आमच्या सरांचा चिरंजीव आहे, कोपीकर सरांचा. ही प्रेझेंटेड फॉर द फर्स्ट टाइम, प्रॉब्ली आय लिसन टू हिम फॉर द फर्स्ट टाइम. आणि कविश आणि तृप्ती मॅडम आता एक्सपर्ट झाल्यात बऱ्यापैकी. 10 मिनिटात खूप चांगलं प्रेझेंट केलं. आर्टिकल प्रेझेंटेशन खूप छान होतं आणि एक्सपर्ट्सनी खूप छान अनालिसिस केलं. Perfect analysis from both the sides, why this article selection, and the critical analysis from experts point of view, especially Sandeep and Sushant. Both of them did huge good analysis आणि याचा बरंच critical analysis असल्यामुळे डे टू डे प्रॅक्टिस मध्ये खूप चांगला त्याचा फायदा आम्हाला सगळ्यांना होईल. थँक्यू व्हेरी मच. IIP रायगड महा IIP प्रेसिडेंट हेमंत गंगोलिया सर, अमोल पवार, जय भंडारकर, निलिमा मॅडम, नंतर स्नेहा सिंग, चित्रा कुलकर्णी मॅडम. थँक्यू व्हेरी मच फॉर गिव्हिंग अ वंडरफुल सॉर्ट ऑफ दिस जर्नल क्लब किंवा जर्नल काय नाव दिले, जर्नल जर्नी. तो अँड आय सपोज जर्नल जर्नी and I suppose this will be for every Sunday now. I am not aware.
First day of every month.
चालू होईल असं.
Kedar sir, it is the first day of every month. First day of every month.
Okay. Good. So once in a month it will be there. Okay, good. Okay.
Thank you, Kedar sir. Yes, sir. Now I request IIP Raigad Secretary Dr. Dhananjay Rajput sir for the vote of thanks. Over to you.
Thank you, madam. Once again, it was a wonderful and academically power-packed session of Journal Journey. 3 articles related to our day-to-day practice were nicely covered in such a short time. First of all, sincere thanks to Dr. Vijay Kamble sir for his guidance for this Journal Journey. We are lucky to have Dr. Nanivdekar sir as a guest of honor today. Thank you, sir, for your blessings. Sincere thanks to Dr. Gangulia sir, our Maha IIP president. We had 2 stalwart experts today, Dr. Sandeep Kadam sir and my dear friend Dr. Sushant Mane. Sincere thanks to both of you for your valuable inputs. Sincere thanks to our today's speakers, Dr. Rahul Kopikar sir, Dr. Kavish Mehta sir, and Dr. Trupti Mahatma madam for your wonderful presentation. Thank you all of you. Sincere thanks to Dr. Jay Bhandarkar sir, the state convener of MahaIP. Sincere thanks to Dr. Chitra madam and Dr. Neha madam for wonderfully moderating this session. And finally, sincere thanks to Ms. Pallavi for making this MahaIP virtual platform available for this session. And finally, thank you all the delegates who have attended this session on Zoom as well as YouTube platform. Thank you one and all. Thank you.
And I appeal to subscribe our MahaIP YouTube channel.
And
So
thank you,
we
Dhananjay.
get notifications.
Dhananjay, not missing anything. Now you are expert in giving Thanksgiving.
Giving thanks.
Jai
Live
Maharashtra.
stream stop karo. Dr.
Thank you.
Neha,
Thank you very much. Thank you very much, everybody.
stop the recording. Dr.
Recording
Neha.
stop करा मैडम. Recording stop करा. करने आता है मैडम को नहीं मालूम नहीं कैसे करना है.
नहीं उन्होंने होस्ट नहीं बनाया मुझे.
नहीं थांबा थांबा.
So
मंगले सर बोला तुम्हारा कैसे करेगा. स्टॉप करता येतं का रेकॉर्डिंग. कुठं करायचं असतं.
No, YouTube live streaming, it is done by host.
होस्ट कोण आहेत. मॅडमच आहेत ना.
डॉक्टर नेहाला बनवलेला आहे होस्ट.
नेहा मैडम देखो हो रहा है क्या. कर सकते हैं.
नहीं सर उन्होंने मुझे होस्ट नहीं बनाया है.
ठीक है.
वो होस्ट.
So thank you very much. We will end
End हो गया.
Thank you, sir. Thank you, everyone.
Okay. Shall we end the meeting then?
Yes.
Yeah. ठीक है. Good night.
Yeah.